This is the third time we're collaborating and doing this event with this group, and it's just been a pleasure dealing with Mr. Scullin and Mr. Bagley, Mr. Cohen, Mr. Montgomery, just surrounding ourselves with people who have such a genuine and authentic concern for individuals with disabilities and special needs. Just to add on to some of Monica's comments, we started about 10 years ago with our program, and we were given by our administration one exam room. So we look back and kind of smile and think about the early days, but we started with 147 children with special health care needs. We had one exam room, and it was just a little bit over 10 years ago. And at this point, we're over 1,800 patients. We are told that by January, February, we're going to get a new area in the hospital that provides up to 8 and 9 exam rooms. So we're really excited about that. To us, it speaks several factors. One is simply the need. There is a need out there. There's a need out there for programs like this where children can obtain appropriate health care services. Whatever we're doing, we feel the most important thing is listening to the parents and developing the relationship of trust and credibility between us and the parents. And I think that has been the hallmark of our foundation of how we continue to grow. So what I'd like to do first is kind of present the landscape of caring for children with special health care needs in the United States. There's this tradition for the current United States presidents over the years annually to present a State of the Union. And during that State of the Union address, he typically will say in the first few sentences, the State of the Union is good, and then he'll go on to talk about statistics and analysis to point that out and as a basis for his comments. Well, I look upon this brief portion of my presentation as the State of the Union for children with special health care needs in the United States. And I would have to say, unfortunately, that the State of the Union is not good. The State of the Union presently is poor. And I would like now to go on to perhaps describe some of the research in the last 10 to 5 years, even some more research that's just coming out in the last 2 or 3 years that will illustrate that. And I do that just so we need to know exactly where we're at before we design implementation strategies moving forward with improving the services. So there have been two major categories of research protocols that have been used to try to capture the essence of the care for children with special health care needs in the United States. One is a quantitative research analysis. This quantitative research analysis is probably what you're pretty familiar with. It's kind of data-driven epidemiological research where these validated phone surveys and questionnaires are used to obtain empiric data. For instance, how many children with special health care needs are in the United States? Where geographically are they located? What are their ages? That's the kind of information that has been obtained, the empiric data. So the next type of research that I also would like to mention is research that is called in the category of qualitative research methods or strategies or protocols. It's contrasted to quantitative studies. The quantitative studies are data-driven. The qualitative studies are what I call narrative-driven. They are simply interviews, open-ended interviews, where the interviewer will go into the home of a child with special health care needs or meet them at school, and they'll ask very open-ended questions to the caregiver, to the parent, to the child, and they'll just say, tell me your story. Tell me about what it's like raising a child with special health care needs. What are your dreams? What are your goals? What are your challenges? What are the day-to-day activities? And then other techniques in this is just simply journaling. They'll ask a caregiver or a parent to journal related to the care of a child with special health care needs. Then this information is gathered. And the type of research is different in that in quantitative studies, they're usually pretty broad studies, sometimes involving thousands of data points, hundreds of thousands at times. Whereas quantitative research generally is done in much smaller forums. 20, 25 individuals get interviewed. And then that data is collated and gathered. And then there's a team of researchers that go through. And what happens during these interviews is they are recorded and then typed verbatim. They're typed word for word so it's not like the person hearing the interview said, I think he's saying this. It's simply what their words are, and then when they go back to look at do the analysis, they simply look through all of the paragraphs were provided, the pages and pages of information, and look for trends, look for motifs, look for themes, look for patterns that have developed across that 25 families that you interviewed. And then that becomes the analysis and the data that you obtain. And my interaction and involvement, we're just doing a qualitative study at St. Christopher's in 15 of our Hispanic families. You know, I've been very pleased and amazed with this type of research because I think it really gives much more of the detail, much more of the reality of what it's like to care and bring up a child with special health care needs. They talk about a subjective reality. You really kind of understand the reality, what the meaning is for that family, what the beliefs, what their values are. I'd just like to mention some of the recent data that has come out with this qualitative research. So here's some of the themes that have been involved in some of the recent research. One of the big ones was that the family simply states, I have a desire to be treated with respect and dignity. That I want my child treated with respect and dignity as I enter into that relationship with the physician's office and in any interaction with the healthcare system. I have a desire to be trusted. So when I go to any healthcare provider or any professional healthcare professional, and I make concerns, I bring up concerns, I bring up issues, I want to be heard, but I also want to be a valued member of the team and trusted. There's a desire that the primary care office to know and understand the needs of my child, including their strengths, their weaknesses. The great appreciation for care coordination. There's this interesting sense of paradox that exists. The caregivers one of the themes that the caregivers do mention that they recount, and some of their words are used specifically in the analysis, they recount the relentless, exhausting features of caring for a child with special health care needs. But then the paradox is that they then say, I would not want a day in my life without this child. They bring great joy and great blessing to it. And it's just been amazing. And we see that day to day. And the fact of isolation. They also talk about this journey into the unknown as that child grows, the journey of as they begin to attain developmental milestones and mature through the organ systems mature. What is that going to entail as they become into middle childhood, later childhood, adolescent, young adulthood? What is all that going to mean? This is a great journey with great unexpectation. But interestingly, again, there's always great hope assigned with this. And also in some of the themes that have come across, they do mention the fragmentation, the complexity of systems, the confusing nature of interfacing, and then this other theme of waiting. There's just a lot of waiting. When they're waiting in the emergency room, when they're waiting to hear back from the physician's office. So that's just, I thought that was interesting, just kind of get a fuller picture of the status of what it is to care for a child with special health care needs. And I know I'm talking to a room of families that are the professionals that enable to give this lecture much better than I would because they live the reality day to day. So I just want to mention a few things about some of the quantitative data, and then I'm going to move on. But the quantitative data, this is from the Maternal and Child Health Bureau, and it all stems from the initial definition that came forth in 1995. And since I don't have my slide, I'm just going to read it quickly. But in 1995, the Maternal and Child Health Bureau adopted the definition of a child with special needs. So here's the definition. Children who have or are at increased risk for chronic physical, developmental, behavioral, or emotional conditions, and who also require health and related services of a type or amount beyond that required by children generally. This really was a big step in adopting a definition. This was in 1995, and since many governmental agencies, many academic-based agencies use this definition to do their quantitative research related to the care of children with special needs in the United States. Previous to this, the data was really, the most sophisticated databases were insurance companies. They had these ICD-9 codes. So ICD-9 code, they could see how many children in their panel have a seizure disorder or cerebral palsy, but really didn't talk about their needs so much. With this definition adopted by the Maternal and Child Health Bureau, it's really needs-based. It's not diagnosis-based. So if a child has a need, then they meet the criteria for having special needs. So this, utilizing this definition, the Maternal and Child Health Bureau, collaborating with the CDC, developed these national surveys of children with special needs. So there have been 3 national surveys. And what they did was kind of operationalize this definition. They operationalized this definition with a 5-point questionnaire that was validated that if you answered these questions, your child would then fit into this definition of having a special need. So the 3 national surveys, the first was 2001, the second was 2005 into 2006, and the last one was 2009 into 2010. So what did they find? Well, they found that in the 3 surveys that were performed throughout the United States did come back with a congruence of statistical analysis that were in agreement. So that was the first thing when they look at the numbers. The numbers were statistically similar each time. And then each time they did this study, they were more sophisticated in the sense that the questions became more in-depth. Once they first identified a child with special needs in the home, then they will go on to ask further questions. Is your child receiving appropriate care? Is there unmet need? What is the stress level of your family? What is the financial status of your family because of that child with special needs? What are your child's needs? And if there's a need for orthopedic equipment, how are you able to receive that orthopedic equipment? So the studies became more sophisticated. But some of the basic, and I'm not going to get pulled down into all the data, but I just want to give you a kind of overview just for the few more minutes that I want to talk about this topic. So 15% of children, that's been a generally accepted number, that 15% of children in the United States meet criteria for having a special need. 7% of children have limitations of activities. 0.2 children have a special health care need that affects their ability and impacts their ability for limitations of activities of daily living. And just one brief thing about this, the 7 percentile. Those children that were had limitations of activities, kind of by definition, that fit into the criteria of a child with a disability. And just to point out, these concepts are complex, and trying to narrow it down into gray and to white and black, they're much gray areas. And I found it interesting that there are actually chapters and books written on the topic of how to define children with disability and adults with disability. And interestingly, there's a little tension even among the disability community and the healthcare community related to the definition of disability. We come from the medical system, and traditionally how we define things is looking at empiric data, using statistical analysis. So there's this normative data, and then I can just quickly use the example of intellectual disability. So how was the term intellectual disability obtained? Well, they got a normative data with an IQ point, and then they decided 2 standard deviations below the mean. That would be, and that IQ, wherever that fell on the line, any child that was below that is in a category that they would say is abnormal. That would be that child has an intellectual disability. Well, interestingly, a disability community comes back and says, who are you as a medical community to tell us who's normal and not normal? So I've grown a lot in my conversations and surrounding myself with those who have expertise in it from the disability community. So just now that further on into some of these more sophisticated analysis, they found 1 in 5 households have a child with special needs. And they've looked now at the child, at the caregiver and parent, and at the family. And all the things that seem very straightforward in a sense, but it is good to document them. So there's an increase in a child with special needs. There's an increased risk of not having access to appropriate care. There's poorer health in general. They have issues related to school, more school missed days, less friends, less ability to make friends, increased mental health services, difficulties with sleep, difficulties obtaining recreational activities. With regard to mental health system, with regard to mental health, there's higher incidence of depression and anxiety. With regard to the caregiver or the parent, increased stress. These are all just things pretty obviously, but at least the data is also backing your intuition, as you know, as you experience in day to day. The parents also have a more likely chance of defining their health as being poor. Parents have an increased rate of doubting their own parent skills. There's increased divorce, increased financial struggles, increased missed days of work. And then with the family, Monica talked about the siblings and the difficulty of the time and the energy that the family needs to spend with caring for the child with special needs and taking away that time and energy, unfortunately, at times from the other siblings. So what are the challenges and what are some of the solutions? Well, one of the big challenges is fragmentation. Our healthcare system in the United States is characterized by great fragmentation. There is poor integration among the systems. And this impacts very significantly those raising children with special health care needs. Just within the healthcare system, there is the primary care provider, there's a specialist, there's a therapist, the physical therapist, occupational therapist, there's the studies, there's the mental health services, there's information flow of the data across these services, there's early interventions. That's just the medical system, and now to even broaden the complexity, the interface with the medical system and that child, with the early intervention system, with the education system, with the intellectual disability system, with the insurance companies, with medical equipment companies. So how do we attempt to move forward in solving this? Well, one of the big solutions we feel is developing relationships which build bridges of communication, build linkages between the systems. So the American Academy of Pediatrics in 1992 came out with this concept called the medical home. And they've also modified their definition of medical home in 2002. So what is the medical home? The medical home consists of a philosophy of care, a concept of care, but also quality improvement initiatives and quality improvement strategies to help outpatient ambulatory care pediatric centers improve their delivery to healthcare services to children with special healthcare needs. So in some of the definitions, when they talk about the medical home, they use these words: accessible, comprehensive, continuous, compassionate, culturally competent, community-based, trust and mutual responsibility. And that's what we try to do. The essence of all this is what we have to do, essentially a central base of medical care. So just to finish up, to talk now about just the next few topics that I want to address is, there's been some great expectations that this medical home concept has been out over 10 years, and when it comes down to it, it really hasn't dramatically changed the impact of the delivery of health care in the United States to the care of children with special health care needs. And why is that? Well, one is the fragmentation. Number two is funding. Where is the funding coming? As we all heard from Monica, that care coordination is so integral. We need to work with our legislatures and those in Harrisburg and even at the national level to make them understand that care coordination needs to be funded. It has to come through the insurance company so that the work, largely in the day, the work that Monica does throughout on the phone with insurance companies, 15, 20 minutes, none of it is funded. So I'd like to give you some pediatric pearls of wisdom. These are just little bullet point facts, high yield information, and I'm just going to leave you with 4 of these little bullet points. So 1 is to be proactive, 2 is to continue to plan, 3 is to develop partnerships, and 4 is to persevere. So just think about every interaction that your child has, and I come from the medical model. So try to be as proactive, organized, and planning with every single aspect and interface with that office. So you have an office visit, and when you're going to come into that office visit, write down what are your priorities. And even what we have seen now is the recommendation that ask the office manager at your doctor's office, can you email them to her or email them to your doctor a day or two before the appointment? Can you fax them to them? Or just get them to him a day or two before, or 5 minutes before the appointment, where he gets a chance to say, okay, this is her priorities. During the appointment, do task allocation. Who's going to take care of this? Is the doctor's office going to take care of this and that? Who's going to take care of what task that will achieve the goals that you want? And then say to the physician, I would like to schedule an appointment in 2 weeks so we can address and see where we're at with this. With regard to the medical office, find out is there a care coordinator in the medical office? Who do you talk to? Get their names. Who does the referrals? Who does the forms? Who does the letter of medical necessities? And the only other thing I'll say from regard to this is studies have shown that the development of an individualized health plan is very important. You're going to hear about the special education services, and strongly hear about this IEP. Well, this is essentially an individualized health plan that has very concrete information. It's going to have information about your child's medications, his nutrition issues, his likes, his dislikes, his activities, if there's any communication impairment and vision impairment, how he best communicates. It's all going to be written down in a document. And then in this document is also to be used longitudinally for when do I have to get my next set of x-rays or lab work. And just use that, work collaboratively, and use that document with the education system, with the early intervention system, and with anyone that interfaces with your child. So the last 2 sentences here, I'm just going to say that the resources that are out there do relate to the medical home. Presently, 49% of children with special health care needs do not have a medical home. So in the Philadelphia area, the academic-based pediatric hospitals, Children's Hospital of Philadelphia has several medical home practices. You can call their main number and ask to talk to an office manager and find out where they're at different geographic sites throughout the city. The St. Christopher's Hospital for Children, in addition to our program, there's 2 other programs within St. Christopher's that has a medical home-based concept. And AI DuPont, both at Jefferson and down in Wilmington, Delaware, also has embraced a medical home. So get your child to a medical home if you have a child with special needs. The Pennsylvania chapter of the American Academy of Pediatrics on its website lists medical home practices that are in the Philadelphia area and in the Pennsylvania area. And then you may have gotten some handouts, or you will get some handouts. On the resources slide, there's these web pages. One is called a medical home portal, and this is from Utah, and it's one of the first resources there. They have so many resources that's downloadable. It's that all these care plans, all these questionnaires and forms are all there and available. So utilize these resources. And so with that, I would just like to say, it has been an incredible, humbling experience where these families with children with special health care needs have let us into their lives, and the joys and sometimes the challenges, but it has been such an incredible richness that has been added to my life. And I would like to thank all of those families that have allowed us to help and assist them on the journey of their caring for their child with special health care needs. Thank you.